Welcome to Beyond the Biopsy. I'm your host, Nitin Yaram, a urologic oncologist at Hackensack University Medical Center. I'm joined today with Corollas Atala, a urologic oncologist at Mount Sinai Medical Center. Welcome, Corollas.
Thanks for having me.
For decades, transrectal biopsy was really the standard when it comes to prostate biopsy, but that's starting to come into question. More recently, transperineal biopsy has seemed to become more ubiquitous. So, Corollas, let's start simple. What are the differences between transrectal biopsy and transperineal biopsy in terms of technique?
So the two methods of biopsying the prostate is, as you alluded to, transrectal and transperineal. The transrectal biopsy is really the timeless procedure to the urologist. It's what we've been doing for decades and decades. It involves placing a probe into the rectum. That's the only way we can really visualize the prostate. And a needle traverses the rectal mucosa into the prostate. So what you're doing is you're approaching the prostate from the posterior direction, from posterior to anterior. The transperineal technique also requires the probe to be inserted into the rectum, but instead of traversing the rectal mucosa, what we do is we put the needle through the skin between the scrotum and the anus. That's called the perineum. So what that translates to is instead of approaching the prostate from the posterior to the anterior direction, we're approaching it from the apex to the base. This is really a burgeoning area of research now as it relates to cancer detection, infectious complications, and peri-procedural pain between these two approaches.
There's so much to talk about in terms of that regard. Why has this become more of a conversation nowadays?
I think it's more salient now because our image-guided diagnostics are becoming so much better. So we have now 3 Tesla plus MRIs, microultrasound, what have you, but really we're entering into this phase of what I would consider organ preservation with prostate cancer. Prostate cancer biologically is a multifocal disease. As we're getting better with our diagnostics, we're now preserving prostates more in the form of good active surveillance protocols and good focal therapy strategies. And that really relies on having a good diagnostic. Determining what the best or the most optimal diagnostic is now important more than really ever.
And I think if we're going to talk about why we're changing, like why we're actually doing this, there has to be an impetus, right? There's a reason why transrectal biopsy per se was really not the greatest tool for our use, right? So let's talk a little bit about that. What is the change? Why are we changing?
The biggest issue that kind of plagued transrectal biopsies was the sepsis complications. If you look at historical data, it was probably on the order of 5 to 7%. Contemporary literature probably puts it between 2 and 4%, much lower. But still, if the median age of diagnosis for men with prostate cancer tends to be between 65 and 70. These tend to be healthier men if we're diagnosing them or working them up with biopsies, but still, your ability to bounce back from something like sepsis at age 65 certainly isn't the same as when we were age 50 or 40. And most clinicians can probably attest to the fact that most folks who've unfortunately had or experienced sepsis, it can be quite devastating. So we've found newer methods from a safety perspective to try to eliminate the use of antibiotics, just to become better stewards of antibiotic administration, and then for the hope of detecting cancers with better accuracy.
So let's talk a bit about that sepsis. You know, when we say sepsis, a bit of a broad terminology, but exactly what do those patients who've had sepsis from transrectal biopsy look like? Are they ones where we're treating outpatient with antibiotics, or is it something that probably requires an inpatient admission with IV antibiotics?
Yeah, sepsis of any kind can be quite devastating. Specifically as it relates to the transrectal biopsy, these patients can decompensate very, very quickly. The rectum is a dirty place, obviously. The prostate is a sterile organ. So when we're traversing the rectal mucosa with a needle, it's direct fecal injection, oftentimes, of the flora in the rectum into the prostate. These patients get very ill very quickly. Unfortunately, there is a very real, very, very small, but a real proportion of patients who unfortunately succumb to sepsis.
Why does transperineal biopsy tend to have less infection risk? And we'll go over the data in a bit, but why mechanistically is it better than transrectal biopsy in that regard?
Sepsis complications tend to be lower with the transperineal route, or at least that's what the promise is, because we're not traversing the rectal mucosa. The needle is piercing through the skin. So the only thing we really have to account for is skin flora. And we can sterilize skin very easily, either with iodine solutions or with chlorhexidine. So same way we do for abdominal incisions. Really, in contemporary literature, the risk of wound infection through the skin is very, very low.
You know, I think a big part of this push that transperineal biopsy is being more and more used, I would also say it has to do with antibiotic resistance and stewardship, right? So let's talk a little bit about that. Is that a big driver for the change for into pushing into transperineal biopsy?
Absolutely. I mean, we just have to be better stewards of antibiotic administration. One of the main drivers of antibiotic resistance is the repetitive use of antibiotics. And actually, in the United States, we have areas that have 30 to 50% resistance to fluoroquinolones, which is tremendous. We need to have good prophylactic antibiotics for the patients who actually need prophylactic antibiotics. And more than that, we're creating these superbugs. So we need to be able to treat patients appropriately who unfortunately do experience infectious complications. I mean, these are, it's kind of a numbers game, right? So patients will experience infections, unfortunately, no matter how much we try to limit it. And if we don't have good fallback options to treat them, then we're doing our patients a major disservice.
On Beyond the Biopsy, we would always like to talk about data. So I think we're going to pivot some of the more recent clinical trials on this topic, right? So the first clinical trial that I think is pretty relevant to all this is the PROBE-PC trial. So can you give us a little bit about the design and kind of what the background is for this trial?
Yeah, so anytime I go through trials with our trainees or our residents, I always tell them to focus on three big things. Take a few steps back, and I think if you can remember just globally what the trial's about, it's very important. So I always say focus on the goals, the findings, and the pros and the cons of the trial. So the PROBE-PC trial was published in 2024. The goals of the trial were really to detect any difference in terms of infectious complications between the transperineal and the transrectal approach. What they found was that there was actually no difference with either approach in terms of infectious complications. They had a pretty broad spectrum for what they considered to be infectious post-procedurally. Now, the pros of this study, this was really the first randomized control trial in this space, and it made us pause. So I think traditionally we always thought that the transrectal approach conferred a much higher risk of sepsis compared to the transperineal approach, but we didn't see that in the trial. With respect to the drawbacks of the trial, 93% of men in the trial were white men in a single center, so certainly limited the generalizability to other practices where we don't see that kind of homogeneous patient population. Another kind of drawback was that almost half, I believe 48% of men had prior biopsies in the trial as well. It's still kind of a debatable topic in terms of what one biopsy confers in terms of risk, lifetime with subsequent biopsies. Certainly there's a cumulative risk lifetime with more than one biopsy. But certainly a salient point that at least half of men in that trial had had biopsies previously.
One thing that I think is always important to note in any of these trials comparing transperineal and transrectal is what was given for each patient, right? So in the transrectal arm, they were given antibiotics, right? And in the transperineal arm, I don't believe they were given antibiotics. Is that correct?
That's correct. So in the transrectal arm, it wasn't targeted prophylaxis. I believe it was fluoroquinolones as the standard use in that single center.
Right.
In the transperineal arm, only 4 patients, I believe, received antibiotics. So it was up to practitioner discretion. But I believe it was a very limited, about 4 patients who received antibiotics.
In total, there was over 800 patients in that trial. So very small amount of patients in the transperineal arm. So I think one common theme that we're going to see in all of these trials is, if nothing else, if everything is equal, the patients would probably benefit from less antibiotics with the equal amounts of, post-sepsis complications or post-biopsy complications. So that's something we'll probably see as a common theme in some of the other trials.
That's exactly right. And the promise there, again, if not from a cost perspective, but just to be better stewards of antibiotics and antibiotic administration is a huge plus.
And again, pivoting to another trial is called the Translate trial. And we saw PROBE-PC, which was in the US, was one of the largest US clinical trials in this regard. The largest is actually in the UK, and I think they looked at over 1,100 men in the Translate trial. So again, to give us kind of those 3 pointers that you gave us for the PROBE-PC trial, for the Translate trial.
Yeah, so the Translate trial was a trial published last year in 2025. The goal of the trial, the primary endpoint was cancer detection, actually. The secondary endpoints were infectious complications and peri-procedural pain. What the trial found was that from the primary endpoint perspective of cancer detection, transperineal actually beat transrectal on the order of about 60% versus 53 or 54%. In terms of secondary endpoints, infectious complications were the same. 0 men in the transperineal arm received antibiotics. All men in the transrectal arm received antibiotics. And in terms of peri-procedural pain, transperineal biopsies, or men who had transperineal biopsies, unfortunately had slightly higher pain scores, but that was transient and kind of dissipated with the ensuing days following the procedure. The pros of this trial was actually powered to detect a difference in terms of cancer detection between the 2 approaches, which I think is one of the strongest parts of the trial.
Sure.
All men were biopsy naive, and all men received a pre-biopsy MRI. The drawbacks of the study, again, generalizability. 93% again of men were white men in rural UK, very homogeneous patient population. So again, limits the generalizability of the data. And then from a technical perspective, if you're looking at who was performing these procedures, so 25% of men in the transperineal arm and 50% of men in the transrectal arm actually had their biopsies performed by a nurse. This is not the standard practice in the US, certainly not to that degree. And there isn't any robust evidence to date that shows that the differences between a clinician, a physician, and a nurse as it relates to the biopsy confers any difference one way or the other in terms of the outcome of the procedure.
You know, I think there's a lot of different theories on this question, but what's your theory on why is it better in terms of cancer detection for transperineal over transrectal?
Yeah, I'll give you a very silly example that I give my patients. A lot of my patients come from the outside who've had prior biopsies, and they always ask, especially for workup of focal therapy, why we need to repeat the biopsy. And I give them a very kind of silly example that I hope illustrates the point. If you have a layered cake of vanilla and chocolate, and I gave you a spoon, and I said, hey, with this spoon, give me 100% of the vanilla layer, you can't approach it from the top down. You have to approach it from the side. So my feeling is that from a mapping perspective, if not, cancer detection from the trials that we're seeing or the sepsis complications, which I truly believe, at least in my practice, I think it is practice dependent, is significantly lower than transrectal approach. From a mapping perspective, I think it's a superior procedure. 100% of your core density is exactly the zone that you want. 70% of cancers are in the peripheral zone, 30% are anteriorly. So your needle, 100% of your needle throw is going to be the zone that you want. So if it's just for purposes of cancer detection, I think it makes no difference. But if we're mapping the prostate for purposes of active surveillance, better active surveillance protocols, and really risk stratifying patients for workup of focal therapy, that approach, I think, makes a world of difference.
Yeah, which again, I think really leads well into the last clinical trial that we can talk about. It's called the PREVENT trial, which the principal investigator is Jim Hu, is here in New York City. But give us a little bit of that synopsis for that trial.
Yeah, so this is a trial published in 2024. The goals of this trial, the primary endpoint was infectious complications between the two arms, transrectal and transperineal. The secondary endpoints were cancer detection and periprocedural pain. In terms of the findings, so infectious complications were similar between the two arms, but with a major asterisk here. So there were 0 events in the transperineal arm, and there were 4 events in the transrectal arm. Overall, low. But if you look at the p-value, we consider anything significant below 0.05, a p-value below 0.05. The p-value between that difference was 0.059. So for me, this is not statistically significant, but it's certainly clinically significant. There were no events in the transperineal arm, and again, there were no men in the transperineal arm who required antibiotics. In terms of the secondary endpoints, there was no difference in terms of cancer detection. And with periprocedural pain, within 1 day periprocedurally, men with the transperineal arm unfortunately had slightly higher pain scores, but that again kind of dissipated after the first 24 to 48 hours, I believe. The pros of this study. So this kind of added to the growing body of literature telling us that maybe we can get sepsis rates and infectious complications on par with transperineal, utilizing the transrectal approach. But I believe a major limitation here is that if you look at the men in the transrectal arm, 100% of them, it was mandatory that they had a rectal swab culture for targeted prophylaxis. That's huge. So if you look at real-world contemporary literature of the actual real-world use of rectal swabs, it's probably less than 4% in the USA. So not incredibly generalizable to the majority of folks who are doing these procedures without rectal swab cultures.
If you're going to say these are the takeaways, I'm going to summarize these 3 clinical trials into a sentence or 2. What is that? What are those takeaways for that?
If we're powering these trials for cancer detection, I think there is superiority of transperineal over transrectal. If we're looking at infectious complications with antibiotics, and sometimes with strong antibiotics, we can get the sepsis rates and infectious complications on par. Pain scores tend to be slightly higher with transperineal, but that tends to be transient.
Yeah. And I don't think we're ever going to see a clinical trial with no antibiotics in either transrectal arm and no antibiotics in transperineal arm, which is obviously what we use standard of care.
Correct.
So we're never going to really know that answer, and obviously it'd be not standard of care to do a biopsy transrectally without antibiotics.
Absolutely.
So we're really going to never know, but I think if there's ever a reason to explain why we would want to push transperineal biopsy, I think antibiotic stewardship is definitely clearly one of them.
Absolutely.
You touched on this next point a bit, and I want you to expand on it in a second, is about focal therapy, the evolving role. I think focal therapy is playing a larger role in prostate cancer care nowadays. Why is transperineal biopsy a better tool over transrectal in this regard, if at all?
Yeah. So the technique that we're talking about has kind of evolved in tandem with the use of MRI in this space as well. So if you look at before versus after the advent of MRI fusion biopsies, now what we're biopsying and what we're diagnosing is about 60% of men with intermediate risk prostate cancer. This is where we derive our candidate pool from for focal therapy. So already we've gotten a little bit better in terms of our diagnostic approach. If we're looking at where transperineal fits in how we look at focal therapy as a whole, it's a more accurate tool. This is not, I always tell patients again, it's unfortunately not like a colonoscopy or a mammogram or a lung nodule biopsy where you only have one spot of tumor and you just got to put the needle in that tumor.
Yeah.
I tell my patients prostate cancer is more like molded bread, unfortunately. So it's kind of peppering the prostate all throughout. Yes, we try to find the index lesion, but we also try to find occult cancers that still can lead to failures down the road.
Sure.
So better biopsy techniques, and again, in my opinion, the transperineal technique versus over the transrectal technique. Better image guided diagnostics up front that triage the need for biopsy initially in the form of a quality MRI. These are really paramount in terms of setting the stage for successful active surveillance and focal strategies.
That's great. Let's pivot again to some more practical concerns about transperineal biopsy. What are some workflow differences between transperineal biopsy and transrectal biopsy? You know, whether it means doing an OR in the clinic, anesthesia. Let's talk a little bit about that.
Yeah, I think it's really practice dependent. So I'll tell you a little bit about my practice. I do pretty much 90% of biopsies in an ASC, in an ambulatory surgery setting, under some general anesthesia.
Sure.
Some propofol like you'd receive for maybe a colonoscopy.
Yeah.
This, I've noticed, is probably not the most common way of doing it. And I think early adopters of this technology or this technique want to do it in an office setting, which is completely reasonable. But you have to look at your constraints and how workflow you can kind of fit this into what you normally do. In my practice in the ASC, we can get turnover less than 10 minutes. So we can do 12 to 15 cases in a day. Patients are happy because we're staying on time. They're receiving high quality care between the anesthesiologists and nurses in the ASC. But certainly if you could mimic that in your office setting, I think that's tremendous. Most of my patients, or I shouldn't say most, maybe about 30 to 40% of my patients have had prior biopsies on the outside and were sent to me. So they actually appreciate that they're going to be asleep for this biopsy. It's not the most pleasant procedure in the world to have a transrectal biopsy while you're awake.
Yeah.
So a lot of them even come in asking for some anesthesia, more than what they receive for the transrectal approach. For the folks who do want to avoid anesthesia, by all means, we book these patients in the clinic and we do under local anesthesia.
Sure. I think one of the critiques of transperineal biopsy is the fact that it may take more utilization of the OR compared to transrectal biopsy, which I'd say a vast majority of times is probably done in the clinic. And I don't know, hard to really know exactly about transperineal biopsy, but it seems to be more of it's done in the OR. So if the major critique here is that there's more utilization of the OR, what's the response to that?
I think as with any new technology or any new technique, there's a learning curve. The transrectal biopsy, again, is something that we've done for a very long time. We've gotten quite good at doing these biopsies very efficiently. The transperineal approach certainly takes a little bit longer initially, especially if you're using fusion. Just the fusion alone on that platform, whatever it is that you're using, is going to add some operative time or procedural time to the case. But I can tell you again, with my own experience, our door in to door out time is about 17 minutes. That's probably on par, just looking at contemporary data with how long these biopsies normally take in the office setting. And there are a lot of things that add to the efficiency, not just the procedural time of what you're actually doing with your hands. Specimen handling is actually a very underappreciated thing in the operating room. Our nurses have kind of gotten it down to a science where they handle the specimens very appropriately, not putting more than 2 per cup, et cetera. So it's one of the more underappreciated things that adds to the efficiency of the case. So as with anything, I think there's a learning curve. Once you overcome that learning curve and build efficiency, not just with what you're doing with your own 2 hands, but what the team around you is doing, I really do believe that you can get the operative times or the procedural times on par with transrectal cases.
How do you counsel patients when it comes down to the differences in terms of transrectal and transperineal in terms of recovery?
Yeah, that's a big thing. So I think when we initially started doing transperineal biopsies, our rates of urinary retention skyrocketed. We were oversampling the transition zone, and it was an area that we had very limited access to with the transrectal approach. Fast forward now with a better understanding of heat map studies that tell us where prostate cancers are, and in the absence of anything visible on your MRI, the chances of finding something occult in the transition zone is very, very low.
Very low.
So depending on the template that you're using, still, I think what contributes to a lot of the peri-procedural pain that you even saw in PREVENT in the TRANSLATE trial was that when you're approaching the prostate from the apex to base, you inevitably have to the needle bypasses the periurethral tissue, which creates a lot of inflammation on top of the transition zone tissue that swells and may lend an opportunity for urinary retention. But more than that, I think the pain comes from the needle traversing the periurethral tissue. And in some cases, we have to go through the urethra for very anterior tumors and midline tumors. So I think that's where the pain aspect comes in. What I tell patients almost reliably, again, just like the PREVENT and the TRANSLATE trial showed, 1 to maximum 2 days of dysuria if they are going to experience it. And it can be quite intense, but it reliably goes away by 48 hours. Which I will say, compared to the transrectal approach, is significantly more painful, at least in the first 24 to 40 hours, but will dissipate after that.
What needs to happen before we can fully move away from transrectal biopsy?
It's a good question. I think, again, as with any new technology, it's very disruptive initially. I teach this technique to a lot of folks, and I see the apprehension. Firstly, again, it's a learning curve. This is not, it's traditionally been a very unsophisticated procedure. Now it's a very sophisticated procedure, especially with fusion technology, et cetera. I've taught folks who have done probably 8,000 plus biopsies transrectally. Teaching the transperineal approach, just like when I first learned it, not having 8,000 transrectal biopsies under my belt, it's a very daunting task. The anatomy actually, it's not just a homogeneous blob of an organ. It's actually not a very intuitive anatomy to view in the transperineal view. So more than that, you have to find a template. You know, the 12-core biopsy doesn't really apply to the transperineal approach. So to select a template, I think, is another daunting task. And it's more so than just putting a needle where the template tells you to. I think it's a thorough understanding of where you want to place your needle and why. So it's now just not kind of an automated biopsy, but a thoughtful procedure. So that's the first thing, is learning curve. The second thing is a disruption in workflow. So, you know, we've gotten quite good at putting, you know, cystoscopies and biopsies into a normal clinic workday without a hitch, you know, with no beats missed here. But with the transperineal approach, especially earlier on the learning curve, it can certainly add some more time to your day. So that might be another kind of workflow disruption, or if you need more operative time, as we all know, operative time is very limited. And then finally, cost. So there's a real cost incurred. I would be surprised if I heard even one urologist doesn't have an ultrasound in their, you know, an ultrasound system in their clinic. This requires kind of a different platform, and at least, you know, can range from $100,000 to $300,000 plus for a fusion biopsy platform with the maintenance included.
To close things out, I'll end with a question we ask all of our guests here at Beyond the Biopsy. And that's, what's one thing that you've changed your mind on in the last few years, clinical or non-clinical?
I would say one thing that I've changed my mind on over the last few years, if we're looking at the data for the trials that we just spoke about alone, it's to challenge dogma. It's to challenge kind of our traditional way of thinking. You know, I personally do pretty much 100% transperineal biopsies. And before this data was published, I would probably swear to you that the sepsis rates were significantly higher with the transrectal approach, even with antibiotics. Although I still do believe, for all the reasons that we mentioned, transperineal is a superior approach to transrectal biopsies. The infectious complications are on par with each other. And that just kind of made me rethink something that I thought was so very obvious. This has kind of translated into many different aspects of my career and even my life, is to kind of challenge the way that we normally view things that we kind of hold as dogma. And what we once thought was a truth standard is to just think twice about it. And that's kind of what I encourage with my trainees as well. Certainly it's something that was imparted on me in training that I think was very valuable.
That's a really great way to end. So thank you so much for joining us on Beyond the Biopsy. Carlos, thank you so much for your time.
My pleasure. Thank you.